Now we are going to discuss the clinical features. Most of early stage cancers are asymptomatic, and how we are going to detect it? Detected incidentally during endoscopy. Why? Because usually these patients are having GERD, and whenever you are performing endoscopy, you are going to find either Barrett's or you are going to find the malignancy. So early stage cancers, these are asymptomatic. The patients are asymptomatic, or patient mimic the symptoms of GERD, or patients are having symptoms of GERD. Clear? Now see the problem. What is happening in carcinoma esophagus? You can see this is the esophagus and this is the stomach. What is the problem? In this, there is a tumor. So you can see here, this is the tumor growth. Slowly, what will happen? The tumor is growing inside the lumen. And if tumor is growing inside the lumen, what will happen? The lumen will be compromised. It is obstructed. So patient will be having dysphagia. Initially, this dysphagia is to solids, then semi-solids, then liquids. So what kind of dysphagia is seen in carcinoma esophagus? This is progressive dysphagia. And the second most common symptom, that is weight loss. So what is the most common symptom in esophageal cancer? Most common symptom, this is dysphagia. This is dysphagia followed by weight loss. An important question, what kind of dysphagia is there? These patients are having what? Progressive dysphagia. So there is progressive dysphagia, means initially to solids followed by semi-solids followed by liquids. So this is progressive dysphagia. Clear? Now imagine there is direct invasion of this tumor into recurrent laryngeal nerve. Because of direct invasion into recurrent laryngeal nerve, what is the manifestation? Patient will be having hoarseness of voice, or sometimes there is vocal cord paralysis. So direct invasion into recurrent laryngeal nerve, it can lead to hoarseness of voice, and vocal cord paralysis. Vocal cord paralysis. Okay. Another important point you can see here. Imagine this is the patient and this is the trachea. What is this? This is the trachea. Clear? This is the tumor. So what happens? Imagine this tumor is going to infiltrate the trachea and there is formation of a communication. So what will happen? Can you see here? Now there is communication between esophagus and trachea. Since there is communication, so what is this? This is tracheoesophageal fistula. So now anything patient is going to drink, anything patient is going to eat, what happens? Even saliva, it can enter the trachea. And whenever it enters the trachea, what is the problem? Patient will be having choking, coughing, cyanosis, dyspnea, or patient will be having aspiration. So patients who are having malignant tracheoesophageal fistula, what are the manifestations here? Patient will be having choking, there is coughing, so there is choking, coughing, aspiration. So these patients are having choking, coughing, aspiration if patient is having malignant tracheoesophageal fistula. Apart from these symptoms, what are the other associated findings? So these patients are having fatigue, these patients have retrosternal pain, and there is anemia. So other associated findings, there can be fatigue, retrosternal pain, and anemia. There is retrosternal pain and anemia. Now tell me, what is the most common site of metastasis? So you know that in GI malignancies, most common site of metastasis, that is liver. So here also, most common site of metastasis, it is liver, followed by lung, followed by bone. So how to remember LLB? It is liver, followed by lung, followed by bone. So this is LLB, liver, lung, bone. This question was asked in one of the latest exam, that what is the paraneoplastic manifestation? Paraneoplastic manifestation associated with adenocarcinoma, and it is motor neuropathy. Paraneoplastic manifestation associated with adenocarcinoma, that is motor neuropathy. This is motor neuropathy. So these are the important points related to clinical features.